Bismillah ar-Rahman ar-Rahim. We are discussing case histories of FGIDs, or disorders of gut-brain interactions. Today is the first case history of the series, that is the IBS patient. The case history number 1, the IBS patient, the caused by stress, visceral hypersensitivity, and dysbiosis. And with the help of this case history, we will try to understand how the stress, visceral hypersensitivity, and dysbiosis contributes to the clinical scenario of typical IBS patient. So it's a case history of 28-year-old female, marketing executives. She has abdominal pain, bloating, and alternating diarrhea and constipation for 2 years. In the triggers, the symptoms gets worsened with stress and during work days. And these symptoms improve on weekends. On the workup, her complete blood count, CRP, stool studies, and celiac serology are normal. So, 28 years old female marketing executive patient presented with abdominal pain, bloating, and alternating diarrhea and constipation for 2 years. The symptoms, they get worsens with stress, and these are present significantly and disturbing her during work days, but these symptoms, they improve on weekends. And on the workup, her workup is normal, including the CBC, CRP, a stool examination, and celiac serology. So, question comes, what's driving her symptoms? So, the possible mechanisms are visceral hypersensitivity, dysbiosis and small intestinal bacterial overgrowth, SIBO, then serotonin dysregulation and motility issues. So, let's consider how the visceral hypersensitivity contributes to the development of her symptoms. In the visceral hypersensitivity, there's increased pain perception due to altered brain-gut communication. So the brain-gut communication is altered, and because of this, the perception of pain is increased. The stress increases corticotropin releasing factor CRF and amplifying gut pain signals, as her symptoms are more during her working days, and it gets relieved to a significant extent on weekends. It tells that the stress of the work increases the corticotropin releasing factor in this patient, and this factor, it amplifies gut pain signals, and therefore there's increased perception of the pain. How the dysbiosis and SIBO contributes? The gut microbiota, we know it influences brain function. We discussed this in the last lecture, the introductory lecture, in fact. The IBS patients have increased firmicutes, reduced bacteroides, and high methane production linked to constipation. So these are the direct effects of the dysbiosis in these patients. Is said there's increased firmicutes in the gut and reduced bacteroides. Then what about the serotonin dysregulation and motility issues? How these contribute to the symptoms? 95%, we know that 95% of the serotonin is produced in the gut, and this is critical for GI motility. The dysregulated 5-hydroxytryptamine receptors, they contribute to IBS diarrhea predominant, versus IBS constipation predominant. So there's a definite contribution of the serotonin dysregulation in the motility of GIT. So in the diagnosis, this case scenario meets Rome 4 criteria for IBS. We should consider additional testing if red flags, right weight loss, anemia, nocturnal diarrhea, family history of IBD. If these were present, then these are the red flags. And in such cases, in IBS patients, when there is weight loss, or the patient is anemic, or patient is nocturnal diarrhea, or family history of IBD, then these should be investigated. I had one patient, he was around 55, 60 years, and he presented to me, and he was being treated as just denutritional anemia and IBS because he was having this altered bowel habits and anemia, and it was thought by the doctor that probably this patient has got IBS, and because of the IBS, his nutrition is affected, so he's become anemic. And when we did the colonoscopy, he was having a big tumor near the cecum, so the colonic tumor. So when there's a red red signs like weight loss, anemia, nocturnal diarrhea, or family history of IBD, the patient should be investigated. And breath test for SIBO if bloating is predominant. If the most of the time is predominant, so you can have the breath test for small intestinal bacterial overgrowth. The management approach for such patients, dietary modifications are the cornerstones. Then the psychogastroenterology, this is again an important component of the treatment, and the pharmacologic interventions. So let's see what dietary modification can help this patient. Low FODMAP diet, that is the fermentable oligosaccharides, they worsen the bloating, so the diet should be less in that. Then the probiotics, certain strains like Bifidobacterium, they help IBS symptoms, and these should be tried. Then coming to the psychogastroenterology, yes, it is a thing. Gut-directed cognitive behavioral therapy, they have shown to improve symptoms as much as diet, and they should not be forgotten. Gut-directed hypnotherapy targets visceral hypersensitivity significantly, and these patients get relieved and feel relieved. Then the pharmacologic interventions, what are these? In IBS dominant, the rifaximin for dysbiosis, loperamide, and tricyclic antidepressants as a neuromodulation should be tried. For IBS constipation predominant, again, lubiprostone, linaclotide, and procalopride. Procalopride is available in Pakistan. Linaclotide is going to be available soon, and lubiprostone, it's not available, but these are the pharmacological options available for constipation predominant IBS. So the key messages from this case history number 1, IBS is not just about the gut. It's about the gut-brain connection. Treating one without the other won't work. So the key takeaways, as mentioned in the previous vlog from these case histories, are that FGIDs, no-called disorders of gut-brain interactions, are real. They are not psychosomatic. The gut-brain axis dysfunction leads to visceral hypersensitivity, dysmotility, and dysbiosis. The diagnosis is clinical according to Room 4 criteria. These should be diagnosed and avoid unnecessary tests unless red flags are present. And the multimodal treatment works best. Dietary therapy plus psychological intervention plus targeted pharmacology. And the future lies in the microbiome-based therapies, that is the postbiotics, fecal microbiota transplants. The gut-specific neuromodulatory, that is the serotonergic agents targeting the ENS. So let's continue the conversation. What's your biggest challenge in managing IBS and functional dyspepsia patient? Please comment below in the comments section. With this, thank you very much for being with me. In the next vlog, we shall discuss the case history number 2 to understand the pathophysiology of disorders of gut-brain interaction. Till then, take care. Khuda Hafiz.